And the first speaker in our next session is Geeta Mehta, who's going to talk to us via a video link from San Francisco. And Geeta is a professor of critical care medicine at the University of Toronto, and she's also the head of the intensive care critical research at the Mount Sinai in Toronto. Geeta presented the results of the sleep study only about 3-4 hours ago at the ATS in San Francisco, and we're very grateful for Geeta to share with us the results of her important study. You will be able to ask Geeta questions after the presentation. Those questions, unfortunately, has to go via me. So I promise no edits on the questions, and Geeta can hear what I say, and you can hear what she will answer. I think the way this is going to run is that Geeta is going to be on one screen. Here she is. And I'm sorry the screen is a bit hazy, but that's because of the large screen, and the slides are going to be on the other screen, and she will be talking to you. Geeta, without taking much more of your time, I wanted to thank you very, very much for sharing the results with us, and we're all looking forward to hear the results of the sleep study.
Hello, Yaya, and hello, everyone. Can you hear me?
Yes, we can.
The sound is good. Okay, well, thank you so much for inviting me, Yaya and Ronaldo. This is definitely a first for me, and it's just amazing to me that I can be sitting in San Francisco and sharing these results with you in real time. I apologize that I didn't adjust my slide and it still says American Thoracic Society, but I'm very pleased to share the results of this randomized controlled trial with you on behalf of my co-investigators and the Canadian Critical Care Trials Group. Our trial was called SLEEP, and the title is a multi-center randomized trial of daily awakening in critically ill patients being managed with a sedation protocol. I don't know if you have an obligation to reveal disclosures, but I have none, other than the trial was funded by the Canadian Institutes of Health Research. The acronym SLEEP is not a mistake. It's not meant to be SLEEP. It is SLEAP, and it stands for Sedation, Lightening, and Evaluation of a Protocol. Over the last 10 or so years, now a little bit more than that, we have learned from some excellent randomized control trials that minimization of sedation improves relevant clinical outcomes, including duration of mechanical ventilation and ICU and hospital length of stay, and possibly reduces the incidence of delirium. And the two strategies that I'm referring to are the use of a nurse-directed sedation protocol and daily sedative interruption. These strategies have been recommended by international guidelines back in 2002. Despite the results of these RCTs and the recommendations of the international guidelines, international surveys demonstrate that there has been poor uptake of these strategies. And one of the reasons is that clinicians continue to have concern, both nurses and physicians, concerned about the use of daily sedative interruption, and primarily these include the risk of patient pain and anxiety during the discontinuation, the risk of endotracheal tube and other device removal, and the additional imposed nurse workload, particularly in centers that don't have one-on-one nursing. Additionally, a recent systematic review of 5 trials that evaluated daily sedation interruption did not find a reduction in the duration of intubation, did find a reduction in the tracheostomy rate, but given the heterogeneity of the trials, called for additional research in the area of daily sedation interruption. So with that background, we asked the question that if a nurse-directed sedation protocol improves outcomes and daily interruption improves outcomes, then we hypothesized that the combination of these strategies, so daily sedation interruption and daily sedation interruption, sedation protocol and daily sedation interruption, might further improve patient outcomes by reducing sedation bioaccumulation. We randomized 430 patients, and in preparation for this large RCT, we conducted a 65-patient pilot to evaluate feasibility, and that was published in Critical Care Medicine in 2011. The large RCT enrolled patients in 14 centers in Canada and 2 in the United States. We had concealed allocation, centralized randomization, and our sample size was based on the ability to detect a 2-day reduction in the time to extubation. With this, we calculated that we needed 205 patients per group. We had an independent DMC who evaluated unblinded results after 50% of patients had been enrolled. We kept our inclusion criteria very broad because we wanted this trial to be generalizable to a wide medical and surgical ICU population. We included adults who were mechanically ventilated invasively and anticipated to need mechanical ventilation for an additional 48 hours or more, in whom the ICU team had decided to initiate continuous opioid and/or benzodiazepine infusions. We excluded patients admitted after cardiac arrest with traumatic brain injury, receiving neuromuscular blockers, although patients could be enrolled once neuromuscular blockers were discontinued, those in whom the team was not committed to complete life support, those previously enrolled in SLEEP or currently enrolled in a confounding trial, and those in whom informed consent was not obtained. The primary outcome of our study was duration of mechanical ventilation, defined as the time from intubation to successful extubation or tracheostomy mask for 48 hours. We had several secondary outcomes, including ICU and hospital lengths of stay, total medication use, nurse and respiratory therapist workload using a visual assessment score, accidental device removal such as endotracheal tubes, gastric tubes, Foley catheters, the use of soft physical restraints. We evaluated delirium in patients daily using the intensive care delirium screening checklist, and we also recorded all neurological evaluation done in the ICU to evaluate decreased level of consciousness. So as I mentioned, both groups were managed with a nurse-implemented sedation algorithm, and the research team did not play any part in sedation management. The nurses followed the protocol and conducted the daily interruption. In this protocol, analgesia could be morphine, fentanyl, or hydromorphone, and sedation could be midazolam or lorazepam. Centers could choose to use either the SAST or the RAST for sedation assessment, and that was done hourly. There was a ventilator weaning protocol I'll show you, and patients in both groups could be managed off protocol if they were paralyzed, on HFO, or receiving palliative care. This probably does not project very well. I'm sorry about that. It has, sorry, did you go on to the protocol slide? This was a two-sided protocol. This shows the front of the protocol, which was simply directed the nurses on how to initiate sedative and analgesic infusions. And I'm not sure if you can read, but at the top of the slide, the priority was to assess pain, manage the pain, and then use benzodiazepine infusions if needed to treat anxiety. Once the infusions were initiated, next slide please, the protocol, the nurses only used this page to the protocol. So with hourly assessment of SAST or RAST, the protocol directed increases or decreases in infusion rates. Importantly, even if the patient was at a goal rate, the protocol directed reductions in infusion rates. As I mentioned, the sedation agitation scale, or the RAST, could be used. The target for the SAST was 3 or 4. The target for the RAST was 0 to -3. Our ventilator weaning protocol permitted PEEP with pressure support weaning. And respiratory therapists screened patients daily in the morning for readiness for a trial of unassisted breathing. And in the box are the 9 criteria that they screened for. If the patient met all of these criteria, then he or she had a 1-hour unassisted breathing trial, either with T-piece, tracheostomy tube, or CPAP 5 centimeters. If the patient passed the spontaneous breathing trial, the team was notified and they made the decision about extubation. Next slide, please. Now, in the daily interruption group, the bedside nurses, again, there was no research personnel at the bedside when the infusions were interrupted, but sometime in the morning, and the team decided what worked best for them, both infusions of opiates and benzodiazepines were stopped. The patient was monitored continuously, and the goal was for the patient to be awake with a SAS of 4 to 7 or a RASS of -1 to +4, and able to perform at least 3 of the following on command: eye opening, tracking of the personnel, squeezing of hands, and moving toes. If, when the patient was awake, the nurse and physician decided that infusions were no longer required, meaning the patient was comfortable and the SAS was between 2 and 5, then infusions were not restarted and oral or bolus IV therapy could be used of opiates and benzodiazepines. If the nurse and the physician decided that infusions were still required, one or both of them were resumed at half the prior doses, again titrated to achieve the target level of light sedation. So we screened 2,091 patients who met the inclusion criteria. 661 were eligible and not enrolled, primarily because of no SDM, consent refusal, and physician refusal. 430 patients were randomized, 218 to the combined group of protocolized sedation plus daily interruption, and 212 to protocolized sedation alone. We used intention to treat analysis such that we did not include patients that withdrew consent, but all other patients were analyzed in the group to which they were initially randomized. These are the baseline characteristics of the 2 groups, and they were very similar. There were no significant differences. The average or the median age was 57 and 60. 44% of patients were female. The Apache 2 score was 23 and 24. SOFA was around 7. And more than 80% were medical patients. However, we did include surgical patients, as I mentioned, and that percentage was around 15%, surgical and trauma patients. The most common admission diagnoses were bacterial viral pneumonia, non-urinary sepsis, and other respiratory disease. Both groups had received a median of 2 days of mechanical ventilation prior to randomization, 1 day of opioid and benzodiazepine infusions prior to randomization, and at randomization, 80 to 90% of patients were already receiving infusions of opiates and benzodiazepines. Here are our outcomes. This Kaplan-Meier curve reflects our primary outcome, the time to successful extubation, which is in the first 28 days. And as you can see here, it doesn't really matter which line is which, but the solid line is the protocolized sedation group, and the interrupted line is the daily interruption group, and the circles indicate patients who were censored due to death or discharge. As you can see, there's absolutely no difference in this Kaplan-Meier curve. The hazard ratio for the daily interruption group was 1.08 with a p-value of 0.495. This slide shows the median duration of mechanical ventilation. It was 7 days in both groups. The ICU length of stay was 10 days in both groups, and the hospital length of stay was 20 days in both groups. It's essentially identical outcome. The ICU mortality was 24 to 30%, also similar in both groups. This table shows the total doses opioids and benzodiazepines that were used, and what we found is that contrary to what we expected, the total midazolam equivalent dose and the fentanyl equivalent dose was greater in the group that was managed with protocolized sedation and daily interruption. And this reflected both doses administered via infusions and intermittent boluses. In addition, the daily interruption group received a greater mean number of boluses of opiates and benzodiazepines per day. The incidence of device removal, gastric tube, endotracheal tube, urinary catheter, and vascular catheters was similar in both groups. Neuroimaging was also similar. The rate of delirium was just over 50% in both groups, and that is defined as ever having delirium. So any patient that had an ICD-SC of 4 during the study would be included in this percentage. And so that's quite high, over 50%. What was more surprising was the use of soft restraints in these 16 ICUs. More than 75% of patients had soft restraints applied at some time during their ICU stay. And then finally, the tracheostomy rate was similar between the two groups. I want to show you some of the data on compliance with the protocol. And the next slide shows all of the SAS scores, and the RAS was converted to SAS for the purposes of display of the data. As I said, the target was 3 or 4, and in the protocolized sedation group, 70% of all values, and this reflects about 50,000 values in each group, were in the target range, and 64% in the DI group were in the target range. Overall, the distribution is very similar, and the mean SAS in the protocolized sedation group was 3.23, and in the daily interruption group, it was 3.28. So patients were kept at a similar level of sedation throughout the study. The compliance with daily interruption DI occurred on 85.6 of eligible patient days, and the mean per patient was 72.2%. In terms of the crossover in the sedation protocol group, on 2.1% of study days, in 16% of patients, daily interruption occurred when it should not have. And this was within an acceptable range. The major reasons that infusions were not interrupted is here. When the nurses did not interrupt infusions, we asked them specifically what the reason was. And as you can see, the most common reason were issues with ventilation. Next, it was concerns about the patient already being in agitation or agitated or being in pain. The next one, 14%, was day 1 of the study. And that implies that the patient may have been enrolled later in the day and the team felt uncomfortable stopping infusions, maybe on the first day of ICU admission before they'd actually gotten good control of the patient's analgesia or anxiety. In 11%, the daily interruption was missed. Other reasons are hemodynamic concerns, airway hemorrhage, physician request, and palliative. Now, clinician workload, I mentioned earlier that we use the visual assessment score. At the end of each shift, we asked nurses and respiratory therapists how difficult was the patient's management during your shift. For nurses, that question related specifically to sedation management. And overall, the distribution of the VAS scores is presented here, and this is more than 8,000 data points. It's reassuring to see that most of the scores fall in the 5 and under categories, meaning that they didn't find this particularly onerous, and it doesn't look, they didn't find it particularly onerous. However, the mean visual assessment score was higher in the daily interruption group. 4.22 versus 3.80 with a p-value of 0.001, suggesting that the nurses found that implementing the daily interruption did increase their workload. This slide shows the distribution of the respiratory therapist visual assessment score, and again, most of the scores are in the 5 and under categories, and contrary to the RN scores, there was no difference between groups here. So for the RTs, they didn't find that daily interruption imposed additional workload. So to conclude, for critically ill mechanically ventilated patients, when nurses implement a sedation protocol in which the target is light sedation, the addition of daily sedation interruption does not improve patient outcomes, including durations of mechanical ventilation and lengths of stay. I mentioned that compliance with daily sedation interruption was 72%, and this compares quite favorably with previous trials. And I have to specify, with previous trials in which ICU personnel conducted the daily interruption. The CREST trial, the compliance was close to 100%, and that's because JP CREST sat at the bedside for each daily interruption, and we know that's not possible in most ICUs. Patients managed with protocolized sedation and daily interruption received higher daily doses of opioids and benzodiazepines, but I don't know the clinical relevance of these greater doses. Despite the greater doses, the durations of mechanical ventilation were the same. There was a perception of higher nurse workload, and daily interruption was safe in that the rates of device removal were similar between the two groups. I'd like to thank the Sleep Steering Committee, who are listed here. Also, all of the investigators that participated in patient recruitment at the 16 centers. And then finally, our data monitoring committee. Jessie Hall was the chair of that. That's it, and I'm happy to take any questions.
Thank you very much, Geeta, for a wonderful presentation. Thank you. I think we'll have time for a couple of questions, and I might start with Ian. What Ian is saying is that you've screened a lot of people, more than 2,000 patients, and you only recruited 20% of those who were screened. Do you have like any form of primary outcome on those who were not recruited? Whether they, with respect to their primary outcome, with their mechanical ventilation time or ICU stay?
I don't, unfortunately. We didn't have RAB approval to follow those patients to look at outcome data.
Yuka is asking about the that you're using a long-acting agents, and what was the average length of the sedation interruption on any one day?
Yes, that's a very good question, and I don't actually have that data quite yet, but I will have it in the future. That's something we're going to look at more closely.
Ronaldo is asking that the gain that you would have on a one day by sedation interruption, would it be lost by having to add a lot more sedatives to get back on control?
You're talking about the increased doses of opiates and benzodiazepines in the daily interruption group?
Yeah.
So that's what I'm proposing, that this reflects nurses' discomfort with patients and attempts to relieve their pain and anxiety immediately after the daily interruption. And I think that's reflected by the greater number of boluses. And one thing we haven't really analyzed is compliance with the protocol, in that did they follow the rates, the permitted rates of increase in those sedative infusions? And my impression is when they restarted the infusions, they probably increased rates more rapidly than permitted by the protocol, just to get the patient under control, essentially overshooting required doses. So Ronaldo, yes, I agree. That's what we propose. It accounts for the increased sedative and opioid uses in the daily interruption group.
Bob is asking about the self-extubation rate, about 5-6%. Is that reasonably high, or is that your kind of normal practice, standard practice?
Actually, that 5% is exactly what an accumulation of all of the previous trials has shown, about a 5% self-extubation rate. That is not our clinical self-extubation rate, so I don't know what it is about these research trials that leads to a slightly higher self-extubation rate. But that, as I said, is right on par with previous trials.
Richard is keen to see it in press.
Oh, I am too. Now, your audience, 70% of them said that daily interruptions should be part of routine care. Do you want to talk about that in the context of this trial?
Yeah, I think we should run that question again after your presentation. I mean, on that, I might just ask you one final question before we let you off to go and have a nice dinner. Just wanted to ask you, is this the end of sedation interruption?
No, I'm glad you asked that question.
Why do you say no?
Because what our trial shows is that when you maintain a light level of sedation using a sedation protocol, meaning that patients are already on the minimal dose required to keep them comfortable, then daily interruption on top of that does not change outcomes. However, if your tendency is to have patients that are over-sedated, or, for example, you have a patient who has been sick for a few days and purposely over-sedated, in that patient, daily interruption may still be of benefit.
Geeta, on behalf of everybody in this room, and wanted to thank you very, very much for giving us your precious time this evening. Congratulations on finishing this study. It's definitely a study that is well needed in this area, and enjoy the rest of the conference, and have a wonderful coming up week. Thank you very much again.
Thank you so much for